Good evening, everybody. I'm Dr. Kelly Teagle from WellFemme, your very own telehealth menopause clinic, and I'm here this evening to present for you a webinar about menopause and intimacy. And to join me this evening, I have my gorgeous friend next to me, Marita O'Shea, who's a pelvic floor physiotherapist here in Canberra. So, Marita, thank you so much for joining us today.
A pleasure, Kelly.
I'm really glad you can be here. So, yeah, to get started straight away, I just want to remind everybody that the information we're presenting this evening is for informational purposes only. It doesn't constitute any individual medical advice in any way, and that you should always consult your own doctor for specific medical advice. Also, just a little bit of housekeeping information for you. Marita and I are going to present for around about 15 to 20 minutes, and at the end of that we're going to have a Q&A session. But you can also type in your questions at any time during the webinar, just using the Q&A button at the bottom of your screen. And then at the end we'll try and address everyone's questions. Now, the webinar recording link is also going to be emailed out to you afterwards, so you'll be able to view it again if you had missed some bits. And it should be available also as a post on the WellFemme Facebook page. Hopefully we're live streaming there at the moment. Hi, Facebookers. So I hope that's all the information you need to get started. Thanks very much for joining us, and we're going to launch straight into our presentation on menopause and intimacy. So to get started, I'm going to share my screen with you. Right, my presentation this evening is going to cover what's normal for sex at midlife, what physical, psychosocial and other factors impact on our sex life at perimenopause, what's going on with our libidos, and how we can improve our enjoyment of sex. Also, Marita is going to cover pelvic floor issues, and she'll be able to tell you all about what causes pain during sex at midlife and beyond. Now, first of all, what is normal for sex at midlife? Well, you might be surprised to hear that 75% of women report problems with vaginal lubrication, 28% experience pain with intercourse, 15% have vaginal itching, irritation or pain, and that these age-related libido problems are very much more a problem of women than men at midlife, and generally getting worse as we get older. Also, changes in the male partner's sexual function can also be the cause of female sexual dysfunction in about a third of couples. This guy here may not have such a big issue, but we can't see, so we're not really sure about that one. Okay, now these are some statistics I had to show you. The main takeaway things from here are that the top 3 sexual problems in the 50 to 59-year-old age group, which you can see here, are number 1, a lack of interest in sex, which is about 2/3 of women. Number two problem is inability to orgasm, so that's in almost half the women, and in equal third place were vaginal dryness and body image issues, which were about 1/3 each. Interestingly though, you can see that women's concern about their bodies seemed to get a little bit better as they got older. In terms of factors that affect our sexual functioning at midlife, the top 3 things that were found in an Australian study of over 400 women were the prior level of sexual functioning. So that means that if you always had a high libido and good sexual function, that you are more likely to experience good sexual function after midlife. And number 2, any change in partners. So if you have a new partner, that has a positive impact on your sexual function, or if you've lost your partner, that has a negative impact on your sexual functioning. And the third thing that affects our sexual functioning at midlife is our feelings about our partner. So what physical changes are contributing at this point? Well, once you stop ovulating and you haven't ovulated for 12 months, that's called menopause. And at menopause, your estrogen levels decline, which cause lower vaginal blood flow and lubrication, and the tissues become thinner. They become thinner and drier and more prone to pain and damage. Also, the vagina is less acidic, more prone to infection, and aging also causes lower testosterone levels, which cause a reduction in sex drive and our sexual responsiveness. On top of that, throw in hot flushes and mood changes, which can make you tired and irritable or affect your mood, even causing mood disorders. All of that makes you not feel terribly sexy at all. And of course, we can't forget the partner factors again there. You know, all of the willingness in the world won't help if he can't rise to the occasion. Now, that's not supposed to be there. Okay, psychosocial factors that are contributing. All right, so you can see there's a list of things here that can impact on your sexual relationship. First of all, whether you like your partner, whether you have a good quality relationship. If you're not feeling very loving or kind, or if you're feeling angry all the time at your partner, it's not very conducive to sex. Issues of grief and loss can really impact on your sexual functioning. Your prior levels of sexual satisfaction, as I mentioned earlier, if you're somebody who's never been particularly interested in having sex or had a high libido, then you're not going to have a high libido postmenopausally either. Your emotional well-being is very important, and whether you're experiencing a lot of stress, you know, maybe stress at work or a family breakdown, and issues of past trauma or having any shame or guilt about sex, maybe in your upbringing, could really be impacting there. Also, a negative body image that doesn't make you feel like, you know, sharing your body with someone else. All right. Other factors that can impact on sexual function at perimenopause are things like general health, whether you've got chronic pain or disease, thyroid problems, for example, menstrual issues, other things that can cause pain with intercourse, and some medications can really impact on your ability to have sex or to orgasm. And of course, if you're not enjoying sex, then you're not going to feel terribly much like initiating or engaging in sex either. So what's going on with libido now? Let's get on to that. I want you to reflect for a minute on which of these two situations might be you. So number one situation is that you don't really much feel like initiating or agreeing to sex, but actually if you do engage in sexual activity, you enjoy it once you get into it, and you can even orgasm. Or you could be the second type, which is that you don't enjoy sex at all. You find it painful or traumatic or upsetting in some way, and you can't get excited or reach orgasm. So, you know, both of these situations are very different in our approaches, and if you would like to know a little bit more about the categories of libido issues and how to maybe approach those, I highly recommend this book, which is Where Did My Libido Go? From Dr. Rosie King. This is a very good primer about libido related issues, and a very good general read, and she's very, very funny as well. Okay, so key points about libido. Libido is a couple-related problem. It's not any one partner that's to blame in this situation, and so it does require, the approach to fixing this requires a willingness to compromise perhaps, and to have open communication about particularly discrepancies of desire between partners. I'm going to include in my resources list an excellent fact sheet about libido from the Jean Hales for Women organisation, and they sum it all up with libido as opportunity, communication, options, and exploration. So with opportunity, think about whether you're creating opportunities for intimacy with your partner, whether you are actually, you know, finding time to spend together where you're not distracted, you're not tired, you're not worried about something else, and you're just focused and attentive on each other. Then think about the type of communication. You need to be open, non-judgmental, and compassionate towards your partner to be able to have discussions like this about really sensitive topics. Then maybe explore your options. Now, if you're in the first category that I mentioned earlier, where you can enjoy intercourse and sex and sexual activity, but you just don't feel like initiating, then maybe decision-driven sex might be the answer for you, which is rather than waiting for desire to overwhelm you and jump your partner's bones, that you actually have to, you know, maybe use some reasoning with yourself to say, well, you know, I know that I'm going to enjoy this once we get started. I know it's good for my relationship. You know, I'll I'll feel like it and get into it more as we go along. So you actually can then rationalize that and you know, make the decision to engage in intimate activity and see where that leads, rather than just saying flat no. Also, maybe explore options for alternative stimulation. You know, you and your partner might enjoy some touch, some massage, you know, viewing some videos together, you know, manual stimulation, oral stimulation, using pleasure products. So there's plenty of things that you can use to help heighten arousal between partners without having to go right through to penetration necessarily, particularly if that's painful for the woman. All right, and exploration there as well is just that whole process of getting to know and explore your own sexuality and your partner's, and learning what gives you pleasure so that you can communicate that to one another, and giving each other honest feedback about that. All right, so just to finish up here, the targeted treatments, and I know Marita's going to go more into this, but for vaginal symptoms, things like lubricants, moisturizers, vaginal estrogens, which can plump up and make the tissues more resilient, it can be really helpful, or the use of dilators for tightness and pain. Things like managing your medical issues, your depression and your chronic pain and things like that that are distracting you from feeling intimate. Managing your other menopausal symptoms, such as flushes that are getting in the way of your sleep and intimacy. Testosterone can be an approach for some women whose responsiveness is not fantastic, but they're, you know, optimizing all the other conditions for good sex. So that's worth talking to your doctor about if you're in that situation. And as I mentioned earlier, pleasure products can be really useful. I'll have some resources available on the write-up after this webinar. But basically, you know, when it takes longer for you to become excited and to get close to orgasm, it can really help speed things up and increase your pleasure if you know that you can reliably become excited fairly quickly. And that's what pleasure products help you to do. So just touching on the resources here, I'm just going to flick them up real briefly. This is the Jean Hales website. Highly recommend that for all this information on sex, relationships and libidos. The Australasian Menopause Society is a great source of reliable evidence-based information. Bliss is a fantastic company selling, an Australian-based company selling pleasure products for women, and also has all manner of fantastic resources available. And I'll have the link to that in our resources too. And this is just one other company, an overseas website called Joe Divine, that markets products specifically for the over 50s. So thank you for listening to that. I'm going to stop sharing my screen now, and we're going to let Marita have a little talk now. So Marita, over to you.
Thanks, Kelly. So yes, I'm a women's health physiotherapist, so I deal a lot with pelvic floor dysfunction, and maybe a lot of you know that we would treat women with pelvic floor weakness with incontinence and prolapse, but a lot of the work I do is actually with women coming in with issues around sex, particularly painful sex. So there's probably two groups of women that I see. So that first group have their tissues in their vagina are affected by the drop in estrogen. So we call that vaginal atrophy, and the tissues can get quite thin around the vulva and the vagina, and it also affects the pelvic floor. So these women will often have pelvic floor tightness and associated muscle spasm, which is what we call vaginismus. So the vaginal walls can become quite dry and fragile, and they are less flexible, and this can lead to considerable discomfort with penetration. And the vagina can actually become shorter and narrower, and again it does, and less elastic, so it doesn't stretch as well as what it used to stretch. And because of this pain and this fear of pain, or the anticipation that sex might be painful, we get like a reflex contraction of the pelvic floor muscles, and that's what's known as vaginismus. So that's a very common scenario in a lot of women coming into menopause. Probably the second group of women I come in with sexual dysfunction are ones that maybe do have prolapse or incontinence, and they have more of a weakness issue. So they tend to have reduced sensation with intercourse, or they'll complain of vaginal laxity and lack of sensation. And other symptoms they can present with is vaginal wind with intercourse, which can be very embarrassing for women, and occasionally even incontinence with either penetration or orgasm. So other issues that they might have if they have a prolapse is that they think that penetration may actually worsen their prolapse, which is usually not the case. And they're usually very worried about what their vagina looks like, what their partner might think it feels like. And although these women don't have pain, they will avoid intercourse and avoid intimacy because it may lead to intercourse. So as a pelvic floor physio, we're trying to improve the function of our pelvic floor muscles, and I hope that most of you know where these muscles are. So Kelly, do you just want to pop that slide up?
Yes,
for me, if you can.
You.
So it's a fairly large group of muscles, and they sit from the pubic bone at the front and run back to the coccyx or the tailbone. And there's two layers of muscles. There's what we call our superficial layer and our deep layer. So the superficial layer of muscles encircle the openings to the pelvic floor, which is the rectum and the vagina and the urethra. And these are the muscles that need to stretch to allow comfortable penetration. The deeper layer are just as important, but they're more involved in improving support if we have prolapse, and also for maintenance of continence for bladder and bowel. And the pelvic floor muscles are really important in sexual function and sexual arousal. So it is important that we look after our pelvic floor muscles, and just to understand that they're like a lot of muscles in our body. They need to function well, they need to be able to contract and be strong, but just as importantly, they need to be able to relax and let go. So as I mentioned, if there's pain, the body's reaction to pain is not to relax, it's to do the opposite, and we tighten up. So I've got another slide here, Kelly, if you just pop that next one on. Mm-hmm. And it kind of talks about this cycle of pain. So the first thing is, if sex is sore that we are going to is painful, we're going to anticipate that. So our body will have this automatic tightening of our pelvic floor muscles. So when this happens, the vaginal entry will be even more closed, which will make penetration more difficult, and often it's actually impossible. So the body will brace as a result, will really tense up, will tend to avoid intercourse, and then this cycle kind of perpetuates itself. So it's really important when we're trying to treat women with pain that we're looking at the physical aspects of pain and the muscles involvement, but also looking at our whole body reaction and how we feel about sex. So often it's really useful. In a lot of my patients I will recommend to see, and there's a really good one here in Canberra, to look at seeing a sexual counsellor or therapist, sometimes even psychologists, just to improve that kind of mind-body connection. And I think if it's suggested as part of your treatment, it's a really good thing to be able to do, even though you might feel a bit reluctant. Most women who do find it really, really beneficial. So as a physio, we're looking at relaxing the pelvic floor muscles. And we do that through a variety of means. It's very similar to relaxing other parts of our body. So instead of tightening and squeezing up the pelvic floor, we're actually relaxing and letting it go. And we do this with a combination of breathing exercises. I'll often use certain relaxation techniques, imagery, mindfulness, sometimes even body scanning, because some people aren't aware that these muscles are in tension. So it's really good to be able to learn and recognise what's happening in your own body. When that can be hard, we can introduce things like biofeedback. So these can be little probes that we can actually put into the vagina, and some of them these days are quite technical or technologically advanced, and they have little Bluetooth applicators, and you can get an app on your phone, and there's all sorts of things that we can do to help you, because a lot of women do find this extremely difficult. The other thing that we do in terms of relaxing muscles, and it's like other muscles in our body, is we do relaxation. We do massage to these muscles. And if you've ever had a massage done to other parts of your body, you'll know that massage does increase blood flow. It can improve relaxation and the ability of these muscles to stretch. So it's really important that we do this if we need to for our pelvic floor. It's a little bit more difficult. These muscles are inside. So the massage that we do is internal massage. And again, that can be quite challenging for some women and a bit confronting. But I think if the issues that you've got around painful intercourse are really bothering you, it's a really good thing to be able to do. And sometimes we just need to go outside our comfort zone a little bit. Sometimes we need to be a bit brave and just give these things a go. And it's really amazing what results women can get if you just learn what your body is capable of. And sometimes you just need to relax and try. And if you've got a good guidance of you know, your GP or a good pelvic floor physiotherapist, these things can be less daunting than what you may think.
Yeah, that's a really good point, Marita, because I remember when I was getting ready for childbirth and they talked about doing perineal massage, and that can be quite confronting for someone who's not used to, you know, being told that to touch themselves in a certain way or do certain things. But I mean, it helps to get comfortable with your sexuality, to help to relax, desensitize. So it's important in all kinds of different ways and situations for women's health, isn't it?
It is, and just to be comfortable, because if there was another part of your body that wasn't working, you know, you'd touch it, you'd look at it, you'd stretch it, you'd show someone else. But we're very sensitive to our, you know, vaginal area, and it's a very personal area, very sensitive area. And, you know, there are a lot of women I see that, you know, don't touch their vaginas, and it's okay. It's yours. And if it's not working, you need to kind of find out why it's not working. And I know that can be really confronting for some people, but you know, it can be really, really worthwhile. So I hope that from this discussion that you can take those things away, that it is part of our body, and if we want it to work, and I always think if you want someone else to love your vagina, you've got to love it yourself. You've got to find out where it is and touch it and work out what it can do. So just moving on, just before I finish up, is when we're doing massage and when we're trying to stretch these, you know, the vaginal entry that doesn't do that as well as what it used to, we often use vaginal dilators. So I'm just going to show you dilators. You may have seen them or heard about them. They come in a pack of different sizes, and this is the main type of one that we use, and we use them to massage. So it's a tool to use because it can be very difficult to use your fingers. Sometimes your reach isn't long enough, or some people just don't like that sensation. So these can be quite good to stretch the muscles, and they come in graduated sizes. And the idea really is that we're trying to get our vaginal tissues used to stretch. And we start with the small ones, and as we feel more comfortable, we can move up in sizes. There will be some information on the what Kelly, you're going to send out to people about where to buy them. We use a pelvic floor physio shop that has a lot of good lubricants and good dilators. So just one thing if you are using a dilator, you do need to use a lubricant, and there's lots of different lubricants around. The dilators are either hard plastic or silicone. So if you're using a silicone dilator, you can't use a silicone lubricant because it degrades the material. So you need to use a water-based lubricant. Lubricants are really important, especially as Kelly mentioned, that we don't produce that as much ourselves as we go into menopause and perimenopause. And a lot of women have never used a lubricant before. They kind of don't know where to start. And again, there'll be some information on the different types of lubricant. The one that I tend to recommend, so there's silicone ones, silicone-based, water-based. Some of them have lots of additives. Your typical basic one, which a lot of people go to if they haven't used them, is KY, which is a water-based with glycerin. It's not the best. It doesn't last very long. It dries. And when you're thinking that you need to be doing this sort of work for a little while, it's you're better off getting either a silicone-based one or a natural one. This is probably the best one. This is Olive & Bee. It was actually made by a pelvic floor physio called Claire in South Australia, and it's an olive oil and beeswax. It's called olive oil and beeswax intimate cream, and it's really great for massage. It lasts. It's completely natural, and that's probably the one that I would recommend that you started with. And you can certainly get it. Certain shops have it. You can look online; it will tell you, but you can buy it online as well. So that's probably all I had to. Well, there's probably lots more I could say.
Well, actually, that's very timely, because we've had a question from anonymous attendee, and she's got lots of questions, this anonymous attendee. So yeah, one of the questions was related to lubricants. Were any of them better than the others, and whether natural ones are better? This lady has read that coconut oil can help. I also understood, though, that some of those natural oils like coconut oil you couldn't use with certain things like latex condoms and stuff like that as well.
Yeah, I'm not 100% sure with the coconut oil, but some people do use olive oil, coconut oil. It depends, some of them can be a bit messy because they're quite thin. So look, it really is personal choice. The less additives and preservatives, obviously, the better. So I think it's probably always better to go with something that is natural. And it's really, you know, some people have different skin sensitivities. It's really a matter of just trying.
Yeah,
different ones, really.
Certainly my general advice that I give to ladies who are suffering from vaginal dryness and or pain with intercourse is that for everyday moisturising, so if you've got just discomfort from having the dry vaginal tissues every day, you can use vaginal moisturisers, which tend to be water-based. Things like Silk or Replens are a couple of brands which will be mentioned in the resources. But then for intercourse, generally the oil and silicone ones are a bit better for intercourse because they don't get so readily absorbed into the vaginal tissue, so they tend to sit on the surface and be a bit glidier for longer.
They last longer, yeah.
Yes, exactly. So that's perhaps a good option as well. Okay, well, thank you very much for that. Was really, really helpful and informative. Thank you. I'll slip into a few of these questions that we've got going on here then now. There seems to be a pretty good cross-section of ones for you and for me, Marita. The first one here is, if I feel pain, what can I do? And this actually ties in with some questions that I had ahead of the webinar from a couple of people as well. So Janet had asked me how she can work out what's causing her pain with intercourse, and another question from Angela as to why it burned intensely halfway down the vaginal canal, like a burning ring of fire, she described it, a localised pain which was ruining her intimacy with her new partner. So just to direct everybody to who wants to do some further reading around this, I did write a blog post last year called Love Hurts, which I'll also include the link in our resources, which gives you a basic, pretty good rundown on how to do a self-assessment of where the pain might be coming from, and that gives us some clues as to what the underlying cause of the pain might be. So some of the suggestions that I made in that blog post was to ask yourself, firstly, how old are you? Where the pain is, when does it happen? Have you ever been able to have sex that wasn't painful? Is there anything that looks or feels different? And whether there are any other symptoms or medical conditions that could be contributing. And so it's just a list of questions and explanations there for you to go through to do your own self-assessment of the type of pain you're getting and whether or not that might give you some clues as to what the underlying cause is, so that you can then go and work with your pelvic floor physio or with your doctor to sort that out. So yeah, but I always recommend, regardless of whether you think you know what's happening, to always go to a trusted women's health specialist when it comes to getting confirmation and appropriate treatment for that. Okay, so yes, that's a bit of a rundown on what you can do for pain. Another question from anonymous attendee, Marita. They've asked, can anything help me get in the mood? Any medications that might be recommended? Well, I'll start on that one. You might be able to think of some things too, Marita. Look, when you might have gotten the idea from my presentation that when it comes to being in the mood, I think what you've got to understand is that low libido is normal from midlife. That's the take-home message. So if you're waiting for desire to take you away and you know, feel like you've been gone with the wind and being swept up in the moment, it's probably not going to happen. I think you have to create the mood to get into the mood. So the best way that you can get yourself in the mood is those things that I mentioned, the creating the opportunity things, by making sure you're not tired, you're not stressed, you don't have a bunch of distractions, that you and your partner actually have some time to spend together and engage with one another in a relaxed setting. You know, and from there, it really depends on the individuals. Like, what is it that gets you in the mood? Do you enjoy dancing? Do you enjoy a good laugh together? You know, I mean, if you go and eat a great big heavy meal and get yourself half tanked on 3 bottles of wine, I think that's not going to do anybody's sex life any good, really. But yeah, just focusing on what actually helps you to be relaxed and optimize those conditions, and then just making that decision in your head that, okay, maybe I don't feel like 100% horny right now, but maybe let's just enjoy the company of my partner. Let's get a little bit of touching going on and just see where that leads, and allow yourself to be open to enjoying that and exploring that in an honest way with a partner that you love and can communicate well with. Okay, now here's some more questions. For you, I think, Marita, Carolyn asks, if you start regular pelvic floor exercises, how long would it generally take before you start to see any improvement?
Okay, with strengthening, usually you'll see some improvement. I mean, it depends on what your baseline is, where you're starting from. You'll often see some early improvement in that first 6 weeks or so, and that's not really in strength or bulking up a muscle, but it's more in the neural activation of a muscle. So especially with pelvic floor, some people find it really hard to feel anything and they're not quite sure, and it's because that muscle is quite weak, but sometimes they may have just some neural issues of getting that muscle working. So in the first 6 weeks, you would expect that that muscle would feel a bit stronger, but strengthening takes anywhere, you know, up to 6 months to feel like you're making some improvement. So for example, if you have stress incontinence, and the women that I see, if we've got them on a program of strengthening, you know, we'd really be wanting them to do that for a good 6 months to know that the pelvic floor strengthening was working for that person. So you're in it for the long haul.
Yeah. No quick fixes, sadly. Do you know, a trick that a pelvic floor physio told me once was, because I'm a doctor and I wash my hands lots, was every time you wash your hands, hold a pelvic floor contraction. And probably at times of COVID, we've probably
got very good pelvic floor.
There's 20 pelvic floor opportunities every day for you.
Yeah. I often say to people, do them at teeth cleaning time, because you do it standing, and standing is a very functional position for our pelvic floor rather than lying, and you do it twice a day, and you should do it for the rest of your life. So you do need little triggers, because the issue with pelvic floor strengthening is that people just forget, and it's not a priority, and they don't do it.
That's right. Okay, so a couple of questions about special treatments. Heather asks, what can we recommend for vaginal itching? She's tried non-soap products before. Okay, so when it comes to vaginal itching, there's a bunch of potential causes. There's the obvious ones like thrush, but actually, incidentally, postmenopausally thrush is much less common, isn't it, Marita, because of the reduction in estrogen levels. So unless you're on HRT or using vaginal estrogens, postmenopausally you don't tend to get thrush. If you've got, you know, red, have a look with the hand mirror. If you've got red, inflamed looking tissues externally around the vagina and the vulval areas, you could try perhaps getting a mild hydrocortisone steroid cream from over the counter at the chemist, like Dermaid Soft 1% cream, and apply that a couple of times a day. Because if it's straightforward irritation, say something, a contact dermatitis or some other form of dermatitis, then often those steroid creams can help settle down, and you just need to use that until it goes away. But for the more serious, persistent kinds of vaginal itch, definitely get a proper assessment from your GP, women's health specialist, maybe even a dermatologist. I often will refer my patients that we're not getting anywhere with to a dermatologist who specialises in vulval issues to try and work out what's going on. So yeah, that is our our question related to that. Anonymous attendee who's insatiable wants to know how many days a week and for how long do you need to exercise your pelvic floor? What do you think, Marita?
Well, we should have the aim of doing it each day.
Mm-hmm.
That's always good. Look, it depends on what baseline again that you're coming from, but a strength training program, we would say you're doing 10 to 12 repetitions of a max hold, anywhere between 3 and 8 seconds. Standing, as I said, is a good functional position. And if your pelvic floor is reasonable, you can also add in some quick flex where you're tightening up, letting go. That can be a reasonable thing to do. And then also we can do more of an endurance type exercise where we might do some longer holds for that 10 seconds or a little bit longer and do 2 or 3 of those. So we prescribe programs for pelvic floor muscle training after we've assessed someone, so we've got a good baseline. But if you're doing, a couple of times a day, if you did tie it into cleaning your teeth or in the shower, those triggers, that's quite a useful thing to do.
Okay, great. Like a training regimen, like for any other muscle, really.
Exactly. It's like any other muscle. And if you don't train it and get it strong, it will weaken, and it certainly does as we get a little bit older. So it's a really good thing to be doing. And if you have the aim of most days, then hopefully you'll do it a good 3 or 4 times a week.
Okay. A couple of last questions we've got here, 2 of them that sort of tie in together, which is about vaginal estrogens. Someone asks, can vaginal estrogens help and are there side effects? But also Kate makes the point that having had breast cancer, she can't use estrogen-based creams, and she wanted to know are there other regular creams she could use besides just a lube. So that's a very interesting point you make there, Kate, because most women who've had breast cancer are under strict instructions to avoid all estrogens and all hormones in general, because often the breast cancer has hormone receptors on it, and so it can cause the breast cancer to recur or grow again. Vaginal estrogens, not so much. So the vaginal estrogens are very targeted, and the formulas we have these days with the little pessary tablets and things tend not to actually increase your blood circulating levels of estrogen anyway. So it's a very personal thing, depending on the person's own situation, their type of breast cancer, whether it had receptors, and discussions based on how bad their symptoms are. We would always consult their oncologist about it. But sometimes even after breast cancer, vaginal estrogens are used depending on the person's own circumstances. But generally for someone who hasn't had breast cancer, if your problem is thinning and drying of the vaginal tissues, otherwise known as atrophy, which is a horrible word, the vaginal estrogens can absolutely help. You can see, in some cases, a really magical improvement in just 2 to 3 weeks of using it every day, where you get a nice thickening effect. The tissues are plumper and more resilient and well lubricated, and then you can just drop back the treatment to 1 or 2 a week to maintain that. So it definitely can help a lot. Side effects from vaginal estrogens, generally not, because of that fact that you don't get much in the way of circulating estrogen levels in the bloodstream. But for Kate, post breast cancer, definitely, obviously vaginal moisturizers being used every day, in addition to using specific lubricants for sexual intercourse, will make a huge difference to your ability to have sex without pain. There's even been some studies being done at the moment on testosterone cream that could possibly be used topically to improve the tone of the vaginal tissues in people post breast cancer. But the studies are only in the early days, and obviously they're going to have to assess whether that's safe to use also in post breast cancer patients. So yes, there is a bunch of work going on in this space. I suggest you work very closely with your GP and your oncologist about that. Now, another couple from anonymous attendee. Is it normal to feel itchy and pain for a few days after sex, and what could cause that? Well, so I'll weigh in on this for starters, which is no, it's not itchy. It's not normal to feel itchy and pain in the few days after after sex, but there could be a few reasons for that. If you are perimenopausal, if you've got vaginal dryness, things like that, there could be some micro damage occurring during sex that's causing inflammation of the vagina or vulva. There can be, allergies to products that you're using if you're using lubricants or cosmetics. People have been known to develop allergies against their partner's semen and body fluids. There can be thrush. Thrush generally will make you itchy regardless of having intercourse, but sometimes the male partner will notice that they have itching on the end of the glans penis after intercourse because of irritation from thrush. Any other things you can think of there, Marita, that might cause itching and pain after sex?
Well, in terms of pain, if you have vaginismus and the tightness of the pelvic floor muscles, you tend to get pain during intercourse. Some women do get pain after intercourse. This is quite common often in some of our younger girls that we see with endometriosis who have deeper pelvic floor muscle tone. So those deep muscles, they can often get latent pain afterwards. But generally, if it's a vaginal atrophy issue and a muscle tightness issue, you would actually have pain during rather than later, or you may have both, but it's unlikely to have muscle tightness at the entry and not feel that and only feel it afterwards.
Yeah. So, I think, and again, there's that whole range of possible dermatitises and things like that that can cause skin sensitivities, just like any other part of your body. You can get allergies, sensitivities, abrasions. So all the sorts of processes that can affect the skin in other areas can definitely affect the vulva and vagina. So I would explore that a little bit with your doctor and maybe even a dermatologist if required. Final anonymous attendee question is, can a vibrator be used? Can a vibrator be used to massage the vagina?
Absolutely, really good idea. A really good idea, because you can use it. You can either use it, turn it off, or actually I've got a little one here. Obviously they come in all different sizes. You can use it as a massage tool. And you don't necessarily have to use the massage function. I can't open this if you don't want to, but you can. And a vibration on a muscle is a really, really good thing for blood flow and to soften those tissues. So this is just a little one here. I wouldn't get a big one. I think when you're using a vibrator to try and massage the muscles and improve vaginal stretch, you want to start with something that's fairly small, and I wouldn't be going much more. I mean, it's obviously very individual, but it's not, you wouldn't want anything much bigger than just two fingers width. So they're a good tool to use for massage, but actually pre-intercourse. So often we're trying to get our tissues ready for intercourse, and we do know that when we go through menopause, and I think I was reading this in Rosie King's book, that it takes 15 to 20 minutes for a postmenopausal vagina to be ready for intercourse. Blood flow, thickening of the labia, softening of the tissues, and so using it as a getting ready type of treatment is really good. So definitely, if you're
absolutely. And you make a really good point there with that, because I know I've heard from women with endometriosis who experience a lot of pain with intercourse, that they can actually become desensitized to that pain somewhat and more receptive for intercourse by using the vibrations to stimulate and help bring them pleasure and arousal as well. So they're more well lubricated, they're more relaxed, because you have to be relaxed in order to build arousal. So they're definitely useful tools in a whole bunch of different ways. And another question has just popped up from Anonymous. Are silicone vaginal spaces more comfortable, and do you have any recommendations, Marita?
I'm assuming dilators is what we're talking about.
Look, I'm guessing too.
The one I showed you here is like just a hard medical grade plastic. The silicone ones tend to have a little bit more flexibility in them. Either are fine. There is a couple of brands that we tend to recommend, which again is on the information that will be available. So it's personal choice really, but I think when you've got vaginismus and you're trying to improve the entry or penetration, you're better off to get one with a tapered end. Some of them do have flatter square ends, but you're better off with a tapered end. And the ones on the website that we use, the silicone ones, do have the tapered end. So it's really, either are fine.
Okay, brilliant. All right, well, I think that brings us pretty much to the ends of our questions. There were some other questions, you know, particularly regards vaginismus and things, but I think that you covered off on that pretty well in your presentation, so we won't go specifically into that. I want to thank you again so much for joining us today, Marita. You're just... You ooze professionalism and knowledge. It's so comforting to have somebody that knows so much about this topic to be able to share their experience with us. So thank you very much for that. And all Marita's information and resources I'll be building into the blog post as a backup from our webinar today. So you'll be able to access that through the WellFemme blog page. And I'll also, you know, put out some posts about that on Facebook and stuff when it's ready as well. And hopefully you'll even get emailed it if I'm organised enough. So thank you again, everyone, for attending. I hope you've all enjoyed it and gotten some information, but feel free to get in touch anytime if you need some more information. So thank you. Good evening, Marita. Good night, everybody.
Thank you. Bye.